Hello everyone. Today we will continue with the second part of the cardiac diseases. We will discuss the myocardial infarction as a continuation for the ischemic heart diseases. We will discuss hypertensive heart diseases and some of the cardiomyopathies. So to start with myocardial infarction as one of the ischemic heart disease syndromes. So far, we have discussed angina pectoris, and this is another type of ischemic heart disease or acute coronary syndrome. It is described as necrosis of the heart muscle resulting from ischemia or what we call the heart attack. Definitely, the risk of myocardial infarction increases with age, and it's usually between the ages of 40 to 60 years of age. Less than 10% or 10% occur before the age of 40, and about 45% of cases occur before the age of 65. As you know, men are at a greater risk than women. However, after menopause, the risk is comparable and the gap progressively narrows between men and women. Atherosclerosis is considered the main risk factor for myocardial infarction. The causes in the majority of cases, it's due to a disruption of an atherosclerotic plaque, an erosion or ulceration or hemorrhage within the plaque, as we described in the previous lecture. This will lead to a superimposed thrombosis. So this is in the majority of cases, about 85 to 90%. In 10% of cases, there is no thrombosis, and it is attributed to vasospasm of the coronary arteries. However, less common causes like embolization from a mural thrombus, like an intracardiac thrombus that gives an emboli to the coronary vessels, like in the cases of atrial fibrillation, or due to a severe fixed coronary atherosclerosis, like more than 90% occlusion that will manifest in cases with increased demands on the heart, like with tachycardia, and most of the time these will affect the subendocardial area, and because it is the farmost area from the blood supply and the first to suffer from ischemia. Also, sometimes the problem is not an atherosclerosis or thrombosis, it's due to a small intramyocardial arteriolar disease, like, for example, vasculitis, leading to fibrinoid necrosis and occlusion of the vessel, or sometimes as a consequence of sickle cell anemia and the sickling of the blood cells within the arterioles. Again, the majority of cases are due to the atherosclerotic plaque disruption with superimposed thrombosis. Angiography performed within 4 hours demonstrate the presence of a thrombus in almost 90% of cases. However, sometimes if we perform the angiography or qastra after 4 hours, we might not found the thrombus because it's already lysed, whether spontaneously or by medications. Early thrombolysis is the key process in the successful management and the limiting the extent of myocardial necrosis. The sequence of events that occur in a typical myocardial infarction is first atherosclerotic plaque disruption. Then the platelets adhere to this disrupted plaque because of the exposure of the underlying tissue, and the cholesterol and the collagen is exposed to the blood. So this will start the process of platelet adherence, aggregation, and activation, and release of thromboxane A2. That's why those patients, the first line of management is to give them aspirin, which is an antiplatelet medication to play on this early step of thrombosis. Then there will be an activation of the coagulation system, and within minutes, the thrombus can completely occlude the coronary artery, resulting in myocardial infarction. The patterns of infarction depends on the size and the distribution of the involved blood vessel, because we have main left and right coronary arteries and their branches. So any branch can be affected, وبالتالي the distribution, the size of the infarct will vary, and the location of the infarct will vary. The rate of development of the occlusion, the duration of the occlusion, and the presence of a collateral supply, all of these will affect the pattern of infarction. We have mainly three patterns. We have the transmural infarction, which means that more than 50% أكثر من نص الventricular thickness is affected, and the subendocardial infarctions. These are only limited to the inner third of the myocardium and starting from the endocardium, and this is the first area to suffer from infarction. And we have the microscopic infarcts, mostly in the setting of very small vessel occlusions. The myocardial ischemia leads to myocyte dysfunction, and this occurs as early as 1 to 2 minutes of the onset of ischemia. However, the death of cardiac cells will not occur until 30 to 40 minutes, if you remember the concept of reversible injury and irreversible injury. So, irreversible injury and necrosis will not occur before 30 to 40 minutes. After that, the myocardial damage will start, and in case it is massive myocardial damage, it can cause fatal mechanical failure, in which the pump failure of the heart will take place, and the person or the patient will develop an acute heart failure with pulmonary edema. However, the most common cause of sudden cardiac death in myocardial infarction هو ventricular fibrillation. So, in 80 to 90% of cases of MI, the cause of sudden cardiac death is not the pump failure or the acute heart failure, it is the ventricular fibrillation, which is considered an fatal arrhythmia. So as you can see here, there is this table summarizes the morphologic changes that are seen in myocardial infarction. When I say morphology, I mean the gross morphologic features, the macroscopic, which can be seen by naked eye if we take the heart during autopsy studies, for example, and the microscopic, which are seen on light microscope or sometimes electron microscope. So, in the case of reversible injury, within the first 30 minutes of the infarction, there will be no macroscopic or microscopic findings in the heart. So, if the patient died during this period, there will be no findings in the heart during autopsy. After 30 minutes or 40 minutes, up to 4 hours, also we will not find any macroscopic abnormalities in the heart. After 4 hours, the changes will start. They start with darkening in the color of the affected area of the heart. وهذا الداركنينج بيزيد وبصير dark mottling with bluish discoloration. لكن after 1 to 3 days there will be yellow to tan area of infarction, the area represented by the loss of blood supply. As you can see here, this is the yellow tan area. It corresponds to the area of the infarction or necrosis of the cardiac muscle cells. And after 2 months or 8 weeks, up to years, the only change that we can see is the scarring. It's the same scar thereafter, scarring and fibrosis and collagen deposition at the site of a previous myocardial infarction. As you can see here in this picture, this white area here corresponds to an area of previous infarction with fibrosis and scarring. This area here, which is brown in color, it corresponds to an area of hemorrhage as a result of ventricular rupture after myocardial infarction, which is considered one of the complications of MI. The clinical features, usually patients present with severe crushing substernal chest pain or sometimes a pressure sensation. It can radiate to the neck or the jaw or the epigastrium or the left arm, as we said, and which is considered a referred pain. Lasts for several minutes up to hours, and it's not relieved by nitroglycerin or by rest like in angina. The silent infarctions sometimes may be asymptomatic, and those constitute 10 to 15% of cases, mostly in the diabetic patients or elderly patients. Patients with MI also might have rapid and weak pulse due to the pump failure and decreased workload capacity of the heart, sometimes associated with nausea and sweating and sometimes vomiting. Sometimes those patients may develop shortness of breath and dyspnea from the presence of pulmonary edema as a consequence of acute uh, heart failure, and some of them might develop cardiogenic shock after a massive myocardial infarction, also due to the markedly decreased cardiac output in a failing heart. The diagnosis of MI depends on symptoms, ECG findings, and the measurement of serum biomarkers. These serum biomarkers get access to the blood after injury to the myocardial cells with damage to their membranes, so they gain access to the blood, with the most important of them هم المyoglobin, cardiac troponins, T and I, creatine kinase, and B isoform, which is specific to the heart, because we don't depend on the total level of creatine kinase, because it's also present in other muscles of the body, not only cardiac muscles, but we are interested just in the CK and B because it's the isoform that's specific to the heart, and the lactate dehydrogenase. Mostly we measure the cardiac troponins, we call them cardiac specific troponins because they are not present in other tissues, and the creatine kinase MB. What what marker to measure depends on the duration of the symptoms. The creatine kinase MB activity begins to rise within 2 to 4 hours of MI. So before 2 hours, we will not find elevated levels of enzymes, and they peak after 24 to 48 hours, but they return to normal within 3 days, approximately 72 hours. However, we have the more sensitive cardiac specific troponins, troponin T and the troponin I. Also, they are detectable within the same period of time and they peak at the same period. However, they remain elevated for 7 to 10 days. So if you want to diagnose MI after 3 days of passed on the attack, we need to ask for troponins because the creatine kinase at that time will be normal. Complications of MI include contractile dysfunction with the development of heart failure, papillary muscle dysfunction, and sometimes rupture of papillary muscles وهدول هم المسلز اللي بيمسكوا الهارت valves ممكن يصير عندنا valve problems زي regurgitation. Myocardial rupture زي ما شفتوا قبل شوي في الصورة leading to hemorrhage within the wall that is contained within the pericardium, and sometimes arrhythmias, and the most fatal are the ventricular arrhythmias, which can result in sudden cardiac death. Pericarditis as a complication, it usually develops after 2 to 3 days of MI with a new onset of a different chest pain that is stabbing chest pain, mural thrombus formation due to the stagnation of blood in the heart. Thrombus may develop within the ventricular lumen or the atrial lumen. Ventricular aneurysm dilatation, it can occur as a consequence of transmural infarction of the heart with time. The heart wall will dilate and thins. Some and also the progressive development of heart failure following myocardial infarction. The second topic is hypertensive heart disease. From its name, it's a heart disease develops as a result of hypertension because of the increased demands on the heart and the pressure overload leading to ventricular hypertrophy. If you remember from the cell injury and the adaptation, this is considered an adaptive response, لكن there are limits to this adaptive capacity because if it is persistent, it can culminate in dysfunction of the cardiac myocytes because of their increased demands to oxygen and the relative ischemia that can develop, complicated by cardiac dilatation and congestive heart failure, and even sudden cardiac death. Now, systemic hypertension affects the left side of the heart, while pulmonary hypertension affects the right side of the heart. The left-sided hypertensive heart disease needs these two criteria to be present in order to diagnose. First, left ventricular hypertrophy in the absence of any other vascular cardiovascular pathology, like, for example, a valve problem, without ventricular dilatation until very late in the process. So, late in the process of systemic hypertensive heart disease, patients might develop dilatation. And we should have a history of documented hypertension. It mainly affects the left ventricle, and the left ventricular wall thickness can exceed 2 centimeters, while it's normally between 1.2 to 1.4 centimeters. As you can see here, this is the left ventricular wall. It's markedly hypertrophied and thickened, and this will lead to narrowing of the left ventricular lumen، وبالتالي راح يصير عند البيشنts filling defect and diastolic dysfunction. With time also, the left atrium will dilate, as you can see here, marked by this asterisks, and the patients might develop atrial fibrillation, for example. In long-standing hypertensive heart disease, also dilatation can take a place, not only hypertrophy, but hypertrophy is the hallmark of the disease. The clinical features, patients might be asymptomatic if it is a compensated and adaptive response. However, they might develop atrial fibrillation secondary to the left atrial enlargement. Um, Congestive heart failure if decompensated because the myocytes will fail to contract effectively, as we said, due to the relative ischemia, and the risk of sudden cardiac death is increased. Also, hypertension can accelerate atherosclerosis، فهدول البيشنتس كمان بصير عندهم symptoms and the ischemic heart disease consequences. The pulmonary hypertensive heart disease, or what we call the Pulmonary, it's defined as the right ventricular hypertrophy and dilatation with right-sided heart failure due to pulmonary hypertension, mainly due to primary disorders of the lung parenchyma or the pulmonary blood vessels. Excluded from this definition is the cases of right ventricular failure due to a left ventricular failure, which we call it the congestive heart failure, and due to a congenital heart disease. So there should be an abnormality in the lungs themselves. It can be acute and it can be chronic. Acute, that like what occurs in pulmonary embolism as a complication of pulmonary embolism, and the chronic, like what occurs with the chronic lung diseases, parenchymal diseases, and pulmonary vascular diseases. As you can see here, now in the acute cases, there will be right ventricular dilatation only. However, in chronic conditions, we will find the hypertrophy, as you can see here, there is hypertrophy of the right ventricular wall and the interventricular septum, in addition to the dilatation of the right ventricles. While in the acute cases, only dilatation will take place. The third topic during this lecture is the cardiomyopathies, which are defined as cardiac diseases due to an intrinsic myocardial dysfunction. They can be primary and confined to the heart only, and they can be secondary as the heart involvement in a systemic disorder. It's a diverse group of conditions, including those inflammatory conditions like myocarditis, inflammation of the myocardium, which is usually sometimes it's viral myocarditis, immunologic diseases like sarcoidosis, systemic metabolic disorders like hemochromatosis, in which there is iron deposition in the heart leading to cardiomyopathy, muscular dystrophies, and genetic disorders of myocardial fibers. So it's a diverse group of conditions, and it is divided into three subtypes: the dilated cardiomyopathy, and the hypertensive cardiomyopathy, and the restrictive cardiomyopathy. Every one of them has specific features, like dilated cardiomyopathy results in a systolic contractile dysfunction due to the marked dilatation of the heart, so the contractile ability will decrease and the ejection fraction or the cardiac output will decrease. The causes includes myocarditis, inflammation of the cardiac muscle cells, toxic exposures like for alcohol, and the pregnancy. In 20 to 50% of cases, there will be mutations affecting the cytoskeletal proteins in the cardiac muscle cells. The hypertrophic cardiomyopathy results in hypertrophy of the heart and narrowing of the lumen of the heart. So it will result in diastolic dysfunction and filling problem during the diastole because of the limited capacity of the lumen. Virtually all cases are due to an autosomal dominant mutation in the beta myosin protein heavy chain, making the contractile apparatus in the myocytes, and those usually affects patients in their adolescence in the post-puberty period. The restrictive cardiomyopathy also results in a stiff heart. It's non-flexible, non-compliant myocardium, so also it can result in a diastolic dysfunction and in a filling dysfunction due to deposition of amyloid, increased interstitial fibrosis in the wall of the heart, or sometimes endomyocardial scarring. So these three subtypes, the ejection fraction or the cardiac output during each contraction will differ according to the type of cardiomyopathy. In the dilated cardiomyopathy, the ejection fraction is so much reduced because we said it's a systolic dysfunction, while in the hypertrophic and restrictive cardiomyopathy, there is no problem in the contraction. The problem is in the diastolic filling. So the ejection fraction or the cardiac output during each contraction will be high. However, the total cardiac output will be decreased because of the filling problem and the reduced capacity of the heart. The causes, many of them, they have a genetic underlying causes, especially the hypertrophic cardiomyopathy, but also we always need to exclude cases that mimics cardiomyopathy. So if you remember, dilated cardiomyopathy can occur with hypertensive heart. Dilatation of the heart can occur with hypertensive heart disease. Even hypertrophy can occur with hypertensive heart disease and aortic stenosis, but these are not considered a cardiomyopathy. As you can see here, this is the dilated cardiomyopathy. The wall is may undergo thinning, the lumen is so much dilated, and there is an abnormality in the contractile ability of the heart. This is considered dilated cardiomyopathy. The size of the heart is markedly increased, even it is apparent on chest X-rays. This is the hypertrophic cardiomyopathy, and the hypertrophy of the left ventricle is markedly apparent, as here the lumen also is markedly decreased. The heart shape is like banana shaped ventricular lumen. This is characteristic feature for hypertrophic cardiomyopathy. Sometimes it can, like as I said, it can mimic the hypertensive cardiac disease, but we should exclude hypertension before diagnosing the patient with hypertrophic cardiomyopathy, especially that those cases appears during adolescence and in the post-pubertal period. Thank you.